Okay, so I think we'll begin. Thank you so much, everyone, for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Today's program is a special collaboration between the Blum Center and Mass General Cancer Center in recognition of National Minority Health Month. Before we begin, just wanted to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in reviewing the recording of today's session, feel free to visit the Blum Center website at massgeneral.org/Blum-Center. Please note everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speakers today. If you have any questions for the guest speakers, please use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff, co-host, and the guest speakers will see them. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. And Dr. Moore, would you like to pull up your slides?
Sure.
So next, I would like to introduce you all to Devin Punch. She is the health educator for Mass General Cancer Center, and she will introduce you all to today's speakers.
Thank you, Amy. And thank you, everyone, for joining us today, and to our speakers for being here to present on this very important topic. Today, as part of the talk, Cancer Equity Efforts at the Mass General Cancer Center, we have with us Dr. Beverly Moy, Brenda Lormil, and Evelyn Abayaah. Dr. Beverly Moy is the Director of Cancer Equity, Clinical Director of the Breast Oncology Program, a medical oncologist at Mass General Hospital, and an associate professor of medicine at Harvard Medical School. Dr. Moy's specific research interests include breast cancer clinical trials and racial and ethnic disparities in cancer care. Brenda Lormil is the Health Equity Nurse Practitioner for the Tamir Center for Targeted Therapies at National Cancer Center. She provides patient-centered care to underserved populations while helping them navigate the complexities of Phase 1 clinical trial enrollment. And Brenda is the founder of the Haitian American Medical Association. Evelyn Abayaah is the co-chair of the Mass General Cancer Center Equity Council and the program director of international programs and advisory services. Evelyn is a very active volunteer in her community. She's a founding member of the Acton-Boxborough Racial Justice Group. Thank you all for being here today, and now I turn it over to you.
Thank you very much, Devin, for that introduction. I'm Bev Moy from the Cancer Center, and we're so pleased to speak with you all today about cancer equity efforts at the Mass General Cancer Center. I'm going to turn this over first to my colleague, Brenda Lormil, who will share a patient story to tell you why we are so committed to this issue. Brenda?
Absolutely. Thank you so much, Bev, and thank you for the invitation to speak today about the work that we are doing. Before I jump into this patient's story, I love to, describe health equity, and the best, I would say, definition that I found was the way that the CDC describes health equity as the ability for an individual to fulfill their full health potential without facing obstacles, either from a social position or a socially determined circumstance, which is their social determinants of health. We do understand, we all know that in oncology care, we know that African Americans have the highest mortality rate, lowest survival rate for most cancers. And when we think about those numbers, we can clearly understand that this patient population, they do face many obstacles. Minority populations as a whole, immigrant populations, anybody who is marginalized communities, they face obstacles. It's fair to say that every cancer patient has a fight, but some have a fight that is harder than their counterparts. And this is what I experience in my role here, and this is why I serve. And this patient in particular, she is very special, I would say, to the work that I do, as she's my first patient in the role that I have. She's a patient that we share with Boston Medical Center. And Bev and Evelyn will go into more detail about that work soon later on in the presentation. But I met her in January 2020, last year, a little bit over a year. And I remember getting the information about her from her oncologist back at BMC, where she had to deliver the news to this patient that she had exhausted her treatment options at BMC. And BMC does not have phase 1 clinical trials available to their cancer patients. And again, Bev will talk more about this. And so we're collaborating with them to increase access to those treatment options for the patients that they serve at BMC. But for this particular patient, when she was told that she had exhausted all options, her her primary oncologist offered her to come across town to come to MGH and consider a clinical trial. She is African American at the time. She was in her early 40s with a son who was a couple of months shy of turning 20. And I remember the first time I met her, she explained to me that when her oncologist told her that she exhausted all of her treatment options, she went to Maine. And she purposefully lost contact with her oncologist for 2 to 3 weeks because she wasn't sure what this clinical trial was going to be. And if it's a trial, is it going to work? What's going to happen? She started thinking about the plans that she needs to make and the people that she would, of course, leave behind. I am so thrilled to say she's on cycle 22 of this clinical trial. She has seen her disease shrink, right? She has had more time to spend with her mother, her son. She's still working part-time. She can no longer work full-time. She's still working part-time and she looks amazing and feels amazing. Some of the interactions that we've had when she came here they were a little alarming, but then it shows proof to the work that we're doing here in the Cancer Center when it comes to equity efforts. The very first thing she said to me was, "Oh, there are people like you here." And I understood fully well what she meant by that. And I said, "Of course, and we're here to take care of you." And she over and over and over kept asking me, "Is this going to work? Is this going to work? I am taking a risk." When we think about equity, when we think about some of these novelty therapies that, we are so fortunate to have here at MGH, more exclusively for myself, I sit in the Tamir Center for phase 1 clinical research. These options are not available to all cancer patients, right? Whether it's an insurance issue, whether it's an access issue, whether it's where they're being taken care of, they're not available. So when you think about equity, a huge part is access. For her, she was able to come here, but after the first visit, the first question was, "Are you guys going to pay for my rides to come back and forth?" She has those resources at BMC, and this again opened up another discussion about how do we support these patients that are now willing to come here but have issues with access. And I adore our social work team here and all of the breast research nurses because they got right on top of it to find ways to reach out and find funding to help support her to come to all these multiple appointments, of course, in the earlier phases of her being enrolled on a clinical trial. She's enrolled on a clinical trial. She's had 3 hospitalizations here at MGH. Now, this is someone that you've asked to go from a hospital with a primary team across town to a different team, and now to be admitted for acute care for different issues that were popping up while she was on trial. That can be scary. But the work that we do here is to help folks like her not only find these options when they've exhausted all other options, but also to care for them and make sure that they feel heard, they feel seen, and they're supported. I can say more about other patients that I've had, but she has truly been one of my founding whys to continue to do this equity work. And when you think about it, you always go for the one, right? We want to do a lot. But equity work, it takes time. You celebrate your small wins and you keep moving, but it really does take the effort of everyone. And I'm thankful for folks like Bev and Evelyn and other members of our equity council that are really here trying to make it happen for the folks that can't seem to be seen, heard, or have access to the cancer care that they need along their journey and along their fight.
Thank you so much, Brenda. That was a perfect introduction as to talk about our efforts, because I think it helps ground our discussion about why we're doing what we're doing. This is our Cancer Center Equity Council, which is a multidisciplinary group of leaders and staff members throughout the Cancer Center, comprising medical oncology, surgical oncology, and radiation oncology, who help advise our Cancer Center leadership in all aspects having to do with cancer equity. And Evelyn will go into some of our work a little bit later in our discussion. And here are pictures of some of the key members of our clinical equity team. And I want to point out a few individuals here. Kelly Irwin is a psychiatrist who has really made herself nationally known as an expert in patients with severe mental illness and cancer. And that population has really suffered most really horrible outcomes in terms of cancer survival. And her work has really been tremendous in shedding that into light and coming up with interventions to help. Erica Warner, a very gifted epidemiologist who has done a lot of amazing work in breast cancer disparities. And in the bottom row, these are our patient navigators and community health workers who are just an astoundingly committed group of individuals. Carmen Benjamin, who's been our lead patient navigator for the last 5 years or so, she actually obtained her master's in social work while she was a navigator with us. And we're so pleased that she's continuing along. Osabel Pichardo, actually an undergraduate who just actually got this great fellowship to do more ethics work at Harvard University. Just really amazing people that we are so happy to work with, who help our most underserved patients with cancer. So why do we do this? You know, Brenda told you an individual story, but when you look at the United States and you look at cancer death rates, people who are from minority races and ethnicities have worse outcomes. The fact of the matter is, if you're Black and you have certain types of cancer, you're almost twice as likely to die. And that's the case if you have breast cancer, prostate cancer, gastric cancer, really tremendously disparate outcomes based on race. And as we have made huge strides in cancer treatments, we really have been unsuccessful in closing that disparities gap between the races in terms of cancer mortality. So our cancer equity program, when you think of it broadly, you think about cancer care and research as the discovery of new treatments and delivery of new treatments. You hear that all the time, discovery and delivery. I think that, you know, most of you out there are in the patient and family community. You probably hear a lot about some really phenomenally, frankly, sexy cancer discoveries, like new treatments that have been shown to improve survival by a few %. And actually, even just a couple of days ago, there's this new drug approved by the FDA just on Wednesday called sacituzumab for metastatic triple-negative breast cancer patients. This drug was actually led in development to approval by one of my colleagues in the breast center, Dr. Bardia. And we're incredibly proud of this discovery, and it's going to help many, many people. But then you think about the delivery component. You know, triple-negative breast cancer is a disease that disproportionately affects young Black women. And if you look at the amount of women that participated in those sacituzumab trials, there were less than 5% Black women in those trials. That is a failure of delivery. Now that it's FDA approved, will patients have access and knowledge where they receive their care to be able to get these new discoveries? And the answer sometimes really is no. So delivery, I would argue, is even more important than discovery. If we were able to deliver the best cancer care to all patient populations, we would be making even bigger strides in terms of cancer survival when you think of cancer in a macro level, in a national scheme. This is a major social justice issue. Underserved patient populations are being deprived of some of the best treatments that we have to offer. And when you think about clinical trials, cancer now is a molecularly driven disease because we are really relying on molecular biomarkers to tell us precisely what a patient should be getting for their cancer treatment, which is incredible. But many of those treatments are only available in clinical trials. So if patients aren't getting access to trials, they're not getting some of the best treatment options that they could have. And therefore, even after the trials are done, the results are less applicable to diverse populations if 95% of the patients participating in the trials were white. So that's really kind of the cornerstone of a lot of what we do at the MGH Cancer Center, to provide all the best treatment options possible to all underserved patient populations. Today, we only have a limited amount of time with you, so we're going to talk a lot about the patient navigation program that we have for patients who receive care at our community health centers in Chelsea, Revere, and Charlestown. And then we're also going to talk about our partnership with Boston Medical Center, which Brenda just alluded to. Well, first, I want to describe the patient navigation program that we have with our community health centers. We are actually one of only 7 centers nationally to be funded by a private foundation called the Merck Foundation to provide patient navigation to these patients. And the patients who receive care in Chelsea, Revere, and Charlestown are very underserved. And statistics have shown that cancer survival is far worse in people who live in these populations. The poverty rate in Chelsea actually is 2 times the Massachusetts average. So we implemented a patient navigation program about 4 years ago now. And actually, we haven't yet published our final results because this is an ongoing study. But what we actually have presented at the AACR Disparities Conference is that navigation was incredibly effective in helping patients be able to present to the Cancer Center for their appointments during the COVID-19 surge. And that obviously was a big deal because that was a time where patients were really getting their appointments canceled. Patients were hesitant to come into the hospital for appointments, and the navigators couldn't actually see the patients in person based on some restrictions. So they got on those telephones, they were creative, they had many more contacts with their patients, and the number of missed appointments remained less than 3% pre-COVID and during the COVID-19 surge, which we're incredibly proud of. And we look forward to presenting those results further. But patient navigation has been tremendously important in this very vulnerable population. Boston Medical Center, as many of you know, is the referral center for most community health centers in Dorchester, Roxbury, and Mattapan. And it's the tertiary referral center for Boston Medical Center Health Net patients. This is the largest safety net academic hospital in our area. And almost 60% of the patients who are served there at Boston Medical Center come from underserved populations, and nearly a third do not speak English. This is a remarkable institution that takes great care of their patients. But from a cancer perspective, they do not conduct novel phase 1 trials or industry-sponsored trials. And they could only really have some limited phase 2 or 3 later phase clinical trials within their walls. So that really leads to those patients with cancer served at Boston Medical Center not being able to access some of the most important treatments if they stay at BMC for care. So we, over the years, have built a really wonderful collaboration with the oncologists at Boston Medical Center, recognizing this issue. And this is obviously something that takes many years of trust building and relationships. But through the generous funding of the Treffler Foundation, we were able to launch, actually now over a year ago, a virtual equity hub, where we really wanted to bridge the gap between across town, BMC and MGH, so that we could help our colleagues at Boston Medical Center think about ways to refer patients to us for clinical trials, for them to learn more about clinical trial options, and to frankly share best practices in a very collaborative way, where we could talk about new discoveries in the treatment of cancer. They could talk about how they're tackling issues and resources with social determinants of health. And we decided to do this virtually, actually, over Zoom before the pandemic. So it was almost like it was prescient, because we didn't know what was about to hit us, but we started doing these virtual equity conferences with BMC prior to the onset of the COVID-19 pandemic. So we were able to really bring out these virtual equity hubs and make this successful. We bring specialized oncologic and psychiatric care to community clinicians caring for cancer patients. We're able to offer these specialized services that they may not be able to offer at BMC, such as clinical trials and collaborative psychiatric care. We can work with them to really study the underserved patient populations and think about the ways that the social determinants of health have created barriers for their care. It really has built the capacity of the clinicians in the community, and very, very importantly, has strengthened our collaborations. Since we have started this relationship, we've actually jointly applied for about 3 or 4 research grants together. You know, there've been a lot of back and forth, and it really has created more of a team approach between both institutions and a real camaraderie. These hubs have expanded. We have a breast oncology conference with Boston Medical Center alone once a month. We also have a cancer and mental health virtual conference with our North Shore Community Health Centers. Recently, a neuro-oncology conference with Boston Medical Center once a month has started. And now the Boston Medical Center Thoracic GI and Sarcoma faculty have started to join our general MGH Cancer Center disease conferences as well, because they've heard about, you know, how well their colleagues have, how well it's gone for their colleagues. So this is expanding and is incredibly exciting, and really a great use of our virtual platforms. It also comes at a great time. A little less than, probably about 6 months ago now, the Boston Medical Center, MGH, and Dana-Farber actually formalized a cancer clinical trial collaboration. And through this legal agreement, BMC can now open certain types of clinical trials at BMC so that their patients can stay with their primary oncologist. But it is a limited agreement. They can only open NCI-sponsored trials and certain investigator-initiated clinical trials. So they still can't open those phase 1 or industry-sponsored trials. But being able to formalize this collaboration really creates an environment within the city of Boston that clinical trials should always be considered. And it's really incorporated more into the DNA of the care of cancer for underserved populations. Obviously, I've already talked a bit about COVID-19. You can't have a conference without talking about COVID-19, but this pandemic has really collided in some ways that have provided us some opportunities. It really increased the urgency for virtual platforms, and we feel extraordinarily lucky that we were already starting to do this before, but it really, I think, propagated its success because now people are just so darn used to it. It fostered the collaboration too, because, you know, at the height of the pandemic, we were not able to provide cancer care like we were used to. Surgeries were being canceled. We were thinking more about the immunosuppression of our treatments. So BMC often sought our guidance for the clinical management of the cancer patients, and we were able to share best practices together. Chelsea, you know, our community, our patient navigation program with Chelsea, you know, it was really hard hit by COVID-19, remains very hard hit. It was the biggest hotspot in Massachusetts. So many of our cancer patients actually who lived in Chelsea got sick with COVID-19. And our care really made a difference with, you know, really low mortality due to COVID-19 and really reduced barriers to cancer care among that patient population. But on the challenge side, COVID-19 has created an enormous financial strain on our hospital, which translates into the availability of less resources that we can provide for patients. And so that has created some challenges that we'll have to be facing for years and years now. The other huge crisis that our country has faced over the last year is the effect of structural racism. And, you know, we're now at a time which has been incredibly difficult for many of us, with George Floyd's murder trial ongoing as we speak. And all of these issues have really focused our attention towards structural racism in healthcare and society. So there have been a lot of focus based on our work, and frankly, we're glad that that's happening. We've had a series of town halls among the Cancer Center and Radiation Oncology, with one recently happening after the shootings in Atlanta of Asian workers. And it's really catapulted healthcare equity issues to the forefront. So this is an important time to be talking about all of these issues and coming up with solutions. The impact of all of this on cancer care has been enormous. What we're certainly seeing over the last year is that screening rates for cancers have plummeted. Colorectal cancer, lung cancer screening, cervical cancer screening, breast cancer screening. Just last week, I participated in a webinar with our Boston area community health centers as part of an NCI grant that I'm part of. And we talked to the community health center leadership about how they're doing cancer screening. And they rightly said, our efforts have been on COVID-19 testing and vaccination, and screening has halted. And over the next year, their goals are to try to get back to where we were and try to catch up. And it's all about back to basics. That will mean that we will be treating far more advanced cancers over the next year or two. And there are huge consequences of that. Less patients will have curable disease at presentation. So we're probably going to be seeing worse cancer survival across all populations, but you can pretty much well assure that our most underserved populations will suffer the most. I'm going to turn the discussion over to Evelyn now, who will describe to you our Cancer Center Equity Council. Evelyn?
Thank you, Bev. So you had seen early on in Bev's slides, the group of members for the Cancer Equity Council. Bev and I co-chair that committee, and we actually convened this group after a series of town hall meetings, and became apparent that there was a lot of work that needed to be done, not only in our institution, but internal to the Cancer Center. So some of the goals of the council include we want to address structural and overt racism within the Cancer Center, and especially as it affects our patients and staff. The council is looking to recommend initiatives to reduce structural racism within the Cancer Center, and to the extent that some of that can even trickle down to the larger institution, and complement the efforts that are already underway by MGH and MGB. So we're aligning very closely with Joe Bedencourt and his team on the 10-point plan, and really looking at how we can piggyback on some of those initiatives to address the structural racism for our patients and staff. Another goal that we're focused on is to perform a thorough examination of our operations, our policies and procedures, and view them with an equity lens. So there's a search going on for the chief of radiation oncology, and the search committee was, really looked at diverse candidates and really made an effort to make sure that the candidates that they were putting forward were from all walks of life, and the committee was set up with a diversity lens that included different viewpoints. So these are some of the things that we're doing, and it's out of the work that we're doing, and people are beginning to realize that a search committee has to be really diverse and doesn't always have to be the same group of people, and making the effort to really recruit candidates from all backgrounds. And also to promote and celebrate diversity, inclusion, and multiculturalism in our Cancer Center. We want to be able to really foster our individual differences and make sure that people are feeling welcome irrespective of their backgrounds and country of origin or sexual orientation. Next slide, please. So one thing that we did when we convened the council was really to survey council members and really have them think about areas that they wanted to focus on. What emerged were these three groups. People wanted to focus on access and community engagement, clinical care and research. To Brenda and Bev's point, we want to be able to open our clinical research to underserved minorities and make sure that they're able to come to MGH and access the good care that we have here. And also really examining our staff culture and making sure that every staff member in the Cancer Center is really engaged, feeling welcome, has the respect that they need. And so we have convened 3 work groups that are focused on each of these areas. And each group has a multidisciplinary team, a group of physicians, administrators, nurses. We have based on the group we have as a committee, we've been able to really think thoroughly about how the mixture of each of these groups so that every voice is heard. And each of these groups are focused on different aspects. So for instance, the community engagement group is looking at how can we have community conversations that would really bring other voices, hear what the community wants and how to engage the community. Next slide, please. So this goes into some of the work that group is doing and their recommendations for work. So MG, they want to have a listening tour, and we've reached out to really have, folks tell us which groups out there we should be engaging with. So if you have any suggestions, please let us know. They're working with MGB contracting to expand access. We know that one of the barriers to access in MGH is insurance. So really thinking through how to work with our contracting team to enable patients who currently cannot access care because we do not accept their insurance to be able to come in here. So the emphasis is on Medicare, MCO, and ACOs. Bev talked a little bit about BMC and the work that the Mass General Cancer Center team is doing with BMC, but looking at a BMC Health Net and how patients in that network could access care in our cancer center. And just then some productive talks with Tufts, MCO, and ACOs to see if we'll be able to contract with them to get outpatients. So that group is doing a lot of work in this area to really open up access to underserved patients, to have access to the fantastic clinical research that is happening in our cancer center. Next slide. The clinical care and research group is looking at patient navigation, and Bev shared a little bit about the work around patient navigation and how fundamental and essential that work is to really navigating patients that would necessarily not have come to our cancer center to come to our cancer center. She also did talk a little bit about our collaboration with BMC, which is really exciting, and opening re-access for patients that probably would not have been able to get that. And Brenda's story about that patient that finally was able to make it to our cancer center and the care that she's received and how she's thriving, all this would not have happened without these collaborations. There's a joint application between BMC, MGH, and the DFCI, which is really going to be open, which is really is happening. It's going to open access for a group of patients that we would not get. And culturally tailored patient education materials, that's the area that Devin and Steve and his team really helps us with, so that when patients come in, they're getting patient education materials that are tailored to their needs, their culture, that is culturally sensitive, and that they're feeling welcome and we're engaging them. The other thing that we're looking at is our staff culture. And to Brenda made a very important point. The patient said, I didn't know people like you are here. That is very important. If we want to engage a certain group of patients, we have to do a good job in diversifying our staff and making sure that patients are seeing staff that look like them at all levels, not only the check-in folks, not only the MAs, that the nurses, the physicians are diverse, all that group is diverse, so the patients are being treated by people that look like them, or at least that they see that, I'm coming to a place where they recognize and understand my culture and what I need and my difference. So the staff culture group recently did a survey, and we just shared the results with the Equity Council, but it really did open our eyes to some of the challenges that we're having in the Cancer Center in terms of our staff and engaging patients. We worked with BCG to help us really bring that data to light, and really, and we partnered with BCG actually to do some focus groups as well, not only just survey patient staff, but talk to staff and really hear from them firsthand what they want to see change. So a lot is going to come out of that survey, and we're going to really take it back and think about what are some of the areas we want to work on and make sure that we're moving things forward. Next slide, please. So this a little bit about this survey. We had 500 responses across the Mass General Cancer Center and the Center for Cancer Research. We had 7 focus groups. We talked to female faculty, faculty of color, white faculty, administrators, non-faculty researchers, nurses, to really bring light to what people really want to see change in the Cancer Center and the culture. There were 10 individual surveys as well, really focused on talking to our leadership and just to understand where they are with all of this and what they also want to help change. Next slide, please. So I would wrap up here and turn it over to Bev to talk to you about a recent policy that came about after, just to share a little bit more about the policy. But we're doing a lot of work in the Cancer Center around equity, and we would look to partner with patients, our patients and the staff to really make our Cancer Center more diverse. So Bev, why don't you talk about the policy?
Sure. So the other work that we've been doing within the Cancer Center is partnering with the greater hospital at large about thinking about really our staff culture. And, Evelyn and Brenda have, beautifully touched on the importance of maintaining a really great staff culture and maintaining a diverse workforce. With that is our responsibility to ensure that Mass General is a supportive workplace, that it's a place that we all feel safe working in, and we feel that collaboration and team. The hospital has recognized this, and there have been, as you might imagine, a fairly recent uptick of what we really think is disrespectful and unacceptable patient and family interactions with our staff. And, we've already talked about kind of the tough political environment and, that we have in our country. And the hospital at large has actually revised a policy to respond to discriminatory, disrespectful, and disruptive harassing behaviors among visitors, and come up with a code of conduct. So the Mass General Cancer Center Equity Council helped review this policy with the greater hospital. It really can be more challenging too to have these interactions in the cancer center because, quite frankly, our patients are sick often and they touch multiple areas of the hospital: radiation, medical oncology, surgery, radiology, and they come to clinic and hospital often. They're often admitted to the hospital. And some behaviors can really, if they are prevalent, can really cause staff members of the hospital to feel really pretty abused. And that's not something that we can accept, in this environment. So really, this new policy has broadened expectations about the code of conduct and really saying that, particularly racist interactions are completely unacceptable. And there's a commitment of support from the targeted employee, and the role of the manager and the chief are really discussed. And the hospitals also come up with some scripting for us to really convey these messages to patients and families if these things happen. But in the Cancer Center, we're going a little bit farther in that a group of leaders among the hospital, nursing, and administrative team will be available to help assist our staff if these issues happen, and talk to patients and families to really create a safer environment and a more socially just environment within the Cancer Center, because it all starts with our staff. So those are some of the things that we're doing within the Cancer Center that range from clinical care to research and efforts among our staff. And we're so happy that we were invited to tell you all of these things. And at this time, we're happy to take any questions from any of the attendees.
Thank you so much, Bev, Brenda, and Evelyn. As Bev mentioned, if you have any questions, please type them into the chat box. We can get started with a couple here. What have been some of the biggest challenges in implementing cancer equity efforts?
Bev, do you want to take that?
Well, I would certainly like all of us to, yeah, I can start. Yeah. I think that, you know, it has been wonderful that, frankly, the entire community, patients, hospital leadership, hospital staff have really led to a committed focus on equity issues. When we think about the challenges, though, I think we have to acknowledge that this is a really hard time, obviously in our country, but certainly in healthcare. I think it's no secret that the pandemic has, and I already said this earlier, has created really a financial crisis among hospitals, among our economy. And cancer equity and health equity efforts require resources. Navigation, although our patient navigators are generally community workers, and they don't cost very much, you need a lot of them. You need a lot of, contacts to be able to overcome these barriers. We rely on a lot of foundations to assist us, and Brenda said it earlier, her patient needed transportation help for all of the appointments for clinical trials. And when you're on a clinical trial, that is burdensome. You've got a lot of appointments for scans and visits and treatments. And if you can't afford transportation or don't have ability to do that, you really need to rely on assistance foundations to do that. Well, assistance foundations run out of money easily. So I think that financially, it is a difficult time to come up with new programming, because there are all these competing demands, which are all very worthy. But I do think that it's important for us to, as a community, to prioritize equity, because that's really so important. So I think that's been a really huge challenge that we've faced over the last year. Brenda or Evelyn, do you have any other things that you would add?
Yeah, absolutely. Everyone's here trying to understand the work that we do, and Bev, Evelyn, you guys have explained it. But to piggyback on what Bev has just explained, when you're a provider sitting in this clinic as an African-American female, and you hear about all of the novelty therapies that they're already here, and then the ones that are coming, right? And then our center wants to increase the amount of enrollment that we have because there are more novelty therapies coming. When I think of that, and then I think of the one barrier that might determine if my patient comes back to clinic is a ride, that it's a little disheartening. And then when you think about what you need to do, like I said before, the social workers, we're all over it, and Bev is talking about the patient navigators, but those folks can be in place, but then it's what's the next step? And when you think about the next step, it's usually funding, right? Or you have the conversation with the patient. What are your supports? And they may have wonderful supports, but those supports are not enough. So you think about all of the great innovation that's happening here at MGH Cancer Center, but when you think about equity, you always know, it's always in the back of your mind, okay, they can know about what's happening here. You can offer them to come, but can they really sustain getting their care here? And as a provider, not just a provider, a cancer provider, not just a cancer provider working alongside wonderful folks like Bev and Evelyn, everyone on our committee, I'm also part of that group that's disproportionately affected, right? I identify as an African American, and I see, boy, my people, my parents are from Haiti, these immigrants, these, minority communities, they might not they might hear it, they might know about it, they might want to come, but can they really sustain their care here? And those are part of the things that we want to also help everyone that is watching understand. The work is going to continue, but the work has to be sustained.
I would agree with that. The sustainability of it,
Mhm.
and people, equity work is hard, and it's even harder when you don't have the resources to do the work, right? And you set all these goals that you're not able to achieve because of the limited resources you have. Even adding to what Brenda just said about not sustaining treatment, but we also have a group of patients that are not even able to access the treatment here. And if we had the resources, could we be able to help these patients, irrespective of whether their insurance was received here or not? But there's so many challenges, and it all always comes down to funding. And I think Bev and Brenda both laid it out beautifully. If we had the funding, we could do more. If we could have navigators out there really navigating these patients to us, we could do more. But we have such limited resources, and we're just doing the best we can with what we have right now.
I think I want to also say that it's 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 funding, and then there are other parts to it as well. When you also, again, from my experience, building that trust and that relationship can be a little challenging with the patients and the populations that you want to serve. But as Evelyn discussed, that our committee, a part of our committee, is looking at staff culture. So when you think about doing an intentional search or intentionally diversifying your staff, intentionally training your staff, there are other pieces to it, but it does go back to funding, but it also goes back to creating this group, like the group that is here, right? And then sustaining the work that we do. But more in particular to the patient, you can get the patients here, but creating a strong, robust staff that is supported and that can really be culturally sensitive. And I don't like using the word competent because it's what does that even mean, right? Culturally sensitive to taking care of these patients that may be marginalized in so many different levels when it comes to cancer care.
Actually, yeah, I wanna build on what you just said, Brenda, because I think that's a really important challenge, and that's trust. Anyone who really any expert on health equity will talk a lot about how do you earn the trust of patients. And the thing that I think that is not recognized enough is that many underserved patient populations, most members have had very unpleasant experiences in the healthcare setting in various different ways. So when we're first meeting a patient, we have to acknowledge that they're coming with baggage oftentimes. And that's certainly the case with members of my own family, right? Or other community. Whenever we've done community town halls, I'm always really kind of gobsmacked at the stories that I hear about what's happened with patients in certain healthcare settings. So it can often be more difficult to earn trust. And when someone is diagnosed with cancer, time is of the essence. So you have to create an environment that is safe and welcoming and nurturing. And that begins with our staff. And we have to be sensitive and try harder to earn that trust. So that is definitely a challenge that, you know, we're happy to take on, but it's something that needs to be acknowledged among all staff and patients and families in terms of the hospital community.
Thank you all for that very robust answer. There's certainly several challenges, but you're doing wonderful, making wonderful strides. Are you able to talk a little bit about some of the opportunities or sort of next steps that you envision for the program and for your efforts?
So I guess I can get started. Yeah, there's, that's actually incredibly exciting. You know, I think that we've certainly built an incredible foundation and a great program, but we want to be able to take things to the next level. And really, the sustainability piece is the big issue, right? Because I think that we've been able to do a lot of wonderful things, but we want to be able to make sure that the things we're doing can continue to go on further into the future. And sustainability comes with, really, added resources and being able to disseminate what we're doing. So I think future directions certainly are to expand upon the partnerships that we have and go out to other underserved communities within the Massachusetts area. And that includes, the Cambridge Health Alliance and other places, and create a model that can be used at different cancer centers throughout the country. And that's something that we've already started to embark upon. We've been approached by other leading cancer centers to say, how are you doing this? And how can I do this in my own city? So, kind of a national collaboration of rolling out these programs and showing metrics and proving that what we're doing is working would be, incredibly important as next steps. So that's something that I would be super excited about being able to do in the near future. Bender or Evelyn, do you have other things to add?
In terms of next steps, I can talk a little bit about the Equity Council and what we're doing. As I'd mentioned, each work group is really moving their agenda forward, and the community access work group, for instance, is really hard at work, making sure that they're working with our contracting folks to make sure that patients are able to come here, that we're able to contract with these MCOs and ACOs to provide access to patients. We're working on improving our staff culture. We recognize that we need diverse staff in the cancer center, not just in certain role groups, but across board in the cancer center, making sure that we're intentionally going out and recruiting a diverse group of staff, that when we actually get these patients in, that they're coming and they're seeing that they're people that look like them, and that every person in the cancer center is respected, irrespective of your race, color, creed, sexual orientation. So those are some concrete next steps. And Bev sits on the clinical research portion of the work group, and they're really working hard to expand access. And we've shared some of what has already been done, but to her point, we want to really expand this beyond the few folks that we're partnering with. How can we really partner with folks across the country, make sure that people are able to come to our cancer center? So there's several next steps. It's a long road. I mean, we're taking it. I always say it's equity. The equity work is a big ship, right? It turns slowly. We all have to be patient. That's what I say. It's about patience. It's about doing this very slowly and making sure that we're getting to the end point. Thank you.
Along with all the wonderful next steps that Bev and Evelyn just outlined, another part of when you think about clinical trials in particular, health literacy is huge, right? We can get these folks here, but do they really understand? Do they really understand, like Bev explained earlier, is that cancer care, it's targeted therapy, right? Based off of mutations. Do our underserved community really understand that? And maybe if they understand better and their families and their support systems understand better, they'd be more open to having, even starting a discussion. Also thinking about helping oncology providers, whether you're a PA, NP, MD, whatever whatever credentials you have. When we think about clinical trials, what are we offering them to our patients? Helping folks understand, how many of us are really, deeming patients ineligible because of their social determinants of health, not necessarily because their labs are not appropriate for a clinical trial, but how many of us are really saying that these patients are not eligible for these wonderful novelty therapies only because of where they live or their ability to access care, or their financial socioeconomic status. How much work are we doing to really talk about those challenges on how we address our patients and offer treatment to our patients, but most exclusively, do they understand what clinical trials are and what they're not in this current day and age that we're living in? So there's a lot of work to be done. Yes, Evelyn says it's not easy. Bev says it's not easy, but it's important, and I'm glad that we're here. And Devin, it is exciting to see what MGH Cancer Center is able to accomplish, especially with the partnerships with other hospitals across town. So it's a great place to be, and the work is going to continue, and we're gonna continue doing the work.
I do want to say one more thing too, because you asked about the future. You can't think about the future without thinking about the next generation. And I feel like a very, very important responsibility of our Cancer Center equity efforts is to foster the next generation of future leaders, future physicians, nurses, administrators that are dedicated toward cancer equity. And that means providing training opportunities, research projects. Actually, the Treffler Foundation provided us with funding to give 2 early career investigator awards for faculty for pilot projects in cancer equity. And through that mechanism, we're going to provide mentorship for these investigators, and that request for proposals will be coming out soon. So, in forward thinking, it really is important to build a community of cancer equity researchers and clinicians so that we have that place where people can go to and we can, increase the success of our efforts.
I would agree with that. Very important for us to build future leaders and take this work on. And Bev didn't share, but she has a research grant that she's gonna be, recruiting people like her, young physicians that would take this work on when she moves on. So,
I think you implied that I'm young, so thank you.
You are. But the work has to go on, and we have to build succession plans and make sure that people, there's more people that are engaged in this, that the people that will take this on, the next generation will take this on. And we hope that the work that we're doing today would actually build that foundation, that people will have a better world in the near future. And that, some of the things that we're experiencing right now is just a wave that it will pass, and that the next generation will actually have a better world to live in, where everyone can get along and everyone is feeling respected.
Thank you all so much. We have just about a minute left, so I have one last question. What are some of the things that the MGH patient and family community can do to help cancer equity efforts? Excuse me. You could just touch upon that. That'd be great.
So one quick thing that I would say is that many times, the staff can talk about the importance of these efforts, but the patients and families actually hold a lot more power than we do in many, many, many ways. So if patients and families prioritize this issue and are vocal about it and advocate for these issues, things will happen. So I think that it takes a really meaningful partnership between the hospital staff and the patients and families to forward these efforts.
I would agree.
Well, thank you all again for joining us today, and thank you for everyone who joined. As Amy mentioned earlier, this webinar has been recorded and it will be available on the Blum Center website. Thank you, everyone. Have a great rest of your day.
Thank you so much for having us. Bye-bye.
Bye-bye.